What do you see? What's the reality of delivering IMEs if you're a practicing clinician, you're doing these things? Can you give us any color on what that's like? What's maybe broken in the process? What could be improved?
Yeah, well, I'll say there's a lot of bloat in the system, and I agree with Bob's statement on we want to move these claims faster. And it's really frustrating if I'm treating a patient that's an injured worker that we just sometimes don't get responses from the carrier, and we have to file for petitions and get their attorneys involved to get authorization for care.
All right, welcome everyone to Reimagining Healthcare, a new dialogue with risk and patient safety leaders presented by Medplace. We're excited to bring you conversations with top risk and patient safety thought leaders from organizations around the country. Please subscribe to get the latest news and content. And if you find this episode valuable, by all means, share it with your colleagues. We want to create some meaningful dialogues in your own communities. And if you're interested in participating as a guest, please email us at speakers@medplace.com. You can also check out some of our related content like our articles, videos, and other things at blog.medplace.com/resources. So last time we were joined by Heidi Carpenter, where we talked about outpatient occupational therapy. We got into work comp and some other areas. Today, I'm joined by Dr. Michael Compton, the founder of Renew Health. Welcome, Michael.
Hello, thank you for having me.
So let me give a little bio here. Dr. Michael Compton has been licensed as a doctor of chiropractic, registered nurse, and family nurse practitioner in Arizona since 2010, 2013, 2015, respectively. He's board certified as a doctor of chiropractic by the National Board of Chiropractic Examiners, family nurse practitioner by the American Academy of Nurse Practitioners Certification Board. His clinical practice is focused on the treatment of patients in acute, subacute, post-traumatic, neurological, orthopedic, and pain conditions and associated long-term sequelae. Did I get that right?
Yes, yep.
And a common part of his practice is providing expert witness testimony and independent medical examination services for both plaintiff and defense counsel in liability and industrial injury claims. That's a lot. You've had quite a bit of a career behind you. Did I
Yes.
get everything?
Yeah, well, yeah, it's been a journey for sure, and I sort of just look at this as an evolution of the nature of injury medicine practice. That I personally feel like if I'm not continuously learning, then I'm not doing the best I can for my patients, and also it's quite stimulating for me. I really like what I do, and there's a lot of these types of injuries that we see, and I just want to be on the forefront of what I can for the people that I work with.
That's great. And I love that you do so many things, even on the medical legal front, right? There's so much more we hear this from our physicians on our platform all the time. There's so much more dimensionality that they pick up from their area of practice when they get involved in these kind of medical legal issues, and they get to really kind of see things from other different types of lenses that you don't get trained in medical school on, right? You don't walk out with your degree understanding some of these other implications of practicing medicine, right?
Yeah, I mean, that's, I'll say 100% accurate with that. In my training, I came out of school and knew how to take care of patients to, the level that they teach us in training and whatnot. But when you're a student and when you're, flying on your own, it's a very different um, ball of wax. And then you get involved in medical legal cases, and sometimes you just don't know what you know until you know it.
Yeah.
And that's given me a lot of insight with first in my earlier career learning, just taking care of patients, and then learning how to make causation and apportionments, and dealing with a lot of injuries specifically. Then moving into expert work and IME work, really getting to see the case from a completely different lens, and then taking that back into my clinical practice when I'm working as a treating provider and seeing, oh, well, you know what, this patient has a prior neck surgery. They're here after an industrial injury or an auto or liability, or whatever the claim may be. And now already understanding if I was going to IME my own case, how would I start to put this together? And I think that's really important for people that are heavily involved with injury medicine to have a global perspective of at least.
That's interesting. Yeah, that really resonates. Now, so what's the arc here? Like, how did you get started in pain management, and then how did that segue into work comp and IMEs and things like that?
So, well, I started in healthcare as a chiropractor, and I knew right when I was done with chiropractic school that I wanted more tools in my belt. Chiropractic is great, but it has limitations on scope of practice and perception and where patients see you, what they can do, what you can do for them as a chiropractor. So I went into nursing, and from nursing, I knew that I wanted to go into advanced practice. It was just part of the journey to go into advanced practice. And there's fellowships available for nurse practitioners and additional board certifications beyond the general training. So for me, I knew early that pain management was a big part of just general chiropractic care and musculoskeletal medicine, and I wanted to gain more tools and skills in the general treatment of patients in pain. Specifically in the injury world, most of the time they have injuries from or pain rather from an orthopedic injury, and managing those orthopedic injuries and the pain and whatnot associated with it led me to more medication management and procedural management, which ultimately got me more interested in surgery and dealing with the pain from an orthopedic perspective. Well, yeah, your shoulder's in pain because you have a rotator cuff repair. We could give you medications that will help manage the pain, but really the primary problem is you have a rotator cuff tear or whatever the orthopedic ailment can be. So that's how it sort of just progressed. But my initial interest in pain was because I injured myself when I was in high school and needed pain management services and rehabilitation services. So that's where my interest really started. But as I became a healthcare provider, I realized that every everybody has their role, and I just wanted more tools in my belt to be in my role.
It's great. Yeah, it sounds like that served you well, and it's created a foundation for you also to become seen as an expert by different groups in the space, especially. And it looks like you work with both plaintiff and defense sides, so it looks like they're seeking you out at this point
Right?
to be able to process some of these hard things. Um, let's talk about trends, like interesting things that are going on lately. Like you have a lot of people that are working from home. Is that impacting sort of work-related pain? Like, are there any trends in that happened kind of during or after COVID that you're noticing?
Well, so the one thing I noticed with COVID was that telemedicine was significantly more viable option, right? Because people were not going anywhere really. So I would go to my office and sit in my office by myself because I needed to get out of my house and whatnot. But I just go there and see patients at telemedicine. And I think the answer to that is yes. There's been diminished care from a rehabilitation perspective because it's hard to do tele-rehabilitation, although it's possible. It's just more challenging. It's hard to perform physical examinations in telemedicine, but still possible. And you're having to educate the patient on how to reproduce some of these orthopedic maneuvers, and you're taking the subjective response to the maneuver and test even more subjectively than their response in office. So that's been a little bit challenging, but you do your best with the COVID situation at least. But I think it's also been helpful in just the general spectrum of pain care. Now the DEA has released a statement regarding ongoing controlled medication management. And I carry a fair bit of permanent stationary lifetime award patients that are on controlled medications that need to see me monthly. And they're all over the state. And I saw one gentleman this morning that drove 3 hours to come see me. And now with these changes, he's stable. I monitor him in different fashion. Uh, and now he can come see me once a quarter, or once every 3 months, or 2 months, or whatever I need for more in person monitoring. But uh,
That's interesting.
as far as maybe work injuries related to people working at home. Uh, I haven't seen much of an uptick in that. Um, I've seen a decline in car accidents from people from working from home because
Oh,
they're not traveling as much.
well, that's some silver lining.
Yeah,
That's
yeah.
great.
I mean, if you're not having travel, an hour to
Sure.
work every day, round trip, then your risk for an auto collision is less.
But you've probably seen more people falling off ladders from all the home improvements they've been doing during
Yeah,
COVID, right?
yeah. I mean, we see things like that all the time. People tripping, falling, painting their house, taking down decorations, and things of that nature. Um, whether or not that's a work injury is, debatable.
Yeah.
Depends on, I suppose, what their real role is, and if that's pertinent to their occupation.
There's a lot of chatter around that right now. I know even as a CEO, I myself am paying attention to it. I'm like, is it real? Is it not real? The whole idea that, well, people are working from home, you've got a responsibility in some way to keep them safe, even at home, right? And there's the lawyers are the first ones to the table to talk about the issues on both sides.
Sure.
But yeah, I mean, I see the chatter like that. I do. Just going back to one of your comments you made before about technology. I mean, I'm a technology person, right? First and foremost, it's what I've done my whole career. So I geek out on the technology side of things. And I've seen some really interesting things. And this started 10 years ago when I first got into the venture space. I would see, sleeves and, wearable things that had sensors that could really tell you to the millimeter if the movements were correct, and being able to do this idea of being able to do IMEs remotely, the idea to be able to do PT remotely, all very fascinating. So if at any point you're like, Jerrod, you've got to hear this technology, that kind of stuff is fascinating to me. So if you ever see anything you find interesting in the space,
Sure.
let me
Yeah.
know.
Yeah, the other thing I guess with working from home that I've been getting a fair bit of requests for, and maybe even some challenges, is that a lot of things have changed after COVID with realizing that, do you really need people to come into an office to sit in a cube and to do the job that they could do from home anyway? Um, but having to accommodate for ergonomic workstations, sit to stand desks. I have one patient that has had a complication from a knee surgery and needs to have her entire leg supported. Uh, and, we've gone round and round with the nurse case manager for the organization that she works for. And finally, we were able to get now a 1 year work from home for that person, when previously they were like, well, she can come here and we can give her support. But, I think as you talk to the medical staff associated with the organization, and speak to them versus just filling out a sheet of paper that they're requesting. Um, that's been quite helpful. But I think the biggest thing that I've gotten requests for is more ergonomic workstations, and sitting is not really all that healthy for you. So sit to stand
Sitting
desks.
is the new smoking, I think they're
Yeah,
saying now.
right. Yeah, exactly. Yeah.
Yeah.
So sit to stand desks are a common thing that I will try to accommodate for folks that have back pain or musculoskeletal injuries. I think another real common thing that I see with post-concussion issues is screen filters, light sensitivity from the screens. So
Oh yeah.
accommodating with there's various programs that are available, but some people can't download those programs because of restrictions from their IT department. So like film, or even just glasses, or modified contrast sensitivity programs that they can use on their computer to still accomplish their duties.
Oh, that's great. It's good. Now I'm thinking of all the things that I probably should be providing my employees. Um, let's talk about some of the medical legal stuff, because I think that that's such a mystery to some people, right? If you're not in the middle of it, you hear about it. You might have colleagues that are doing IMEs, but what it feels like and looks like, when you're sitting in the chair doing them. Um, uh, what? So Bob Wisniewski here in town.
I
He's
do, yes.
an attorney representing injured workers. He was on the podcast at one point, and he acknowledged or said basically the whole workers' comp process could be improved if things just kind of moved faster, right? And we're part of the technology inside of the stack to kind of move things faster. But what do you see? What's the reality of delivering IMEs if you're a practicing clinician, you're doing these things? Can you give us any color on what that's like? What's maybe broken in the process? What could be improved?
Yeah, well, I'll say there's a lot of bloat in the system, and I agree with Bob's statement on we want to move these claims faster. And it's really frustrating if I'm treating a patient that's an injured worker that we just sometimes don't get responses from the carrier, and we have to file for petitions and get their attorneys involved to get authorization for care. And it's really challenging sometimes to be able to authorize that or to get the authorizations. And I try to send them back to work as soon as I can with some sort of accommodation. But I also don't know sometimes what's wrong with them because I don't have the imaging or the diagnostic studies that I need, or they have their medicines haven't been approved, or their therapy hasn't been approved, or they haven't even been approved to see me for a follow-up visit. And so it can be quite frustrating. But with in respect to IME services and what can go faster, I think with the IMEs, the adjusters are pretty quick to order IMEs, and I think sometimes rightfully so. And oftentimes those early IMEs are mechanistic questions. Is the injured worker saying that they hurt their knee? Well, maybe they did, maybe they didn't. What was the mechanism of injury? Does that match? They're having compensation with limping. Now they're having back pain. They're trying to get back pain included in the claim when there's no documentation of early back pain. So I always just generally look to the early records as best as possible, but give the benefit of the doubt to the patient on what they're reporting. But we always have to go back to the mechanism of injury to see does that make sense in their claim, and try to push forward with the adjusters. So I'll say the nurse case manager has been super helpful in navigating through and getting
Yeah.
authorization and assistance with authorization. And we try not to get the industrial commission involved, but if the carriers are just not responsive, like we just don't really have a choice. Is that the patient's knocking on our door or coming into the clinic or messaging the office saying, hey, what's going on? Nobody's contacted me for this imaging. It hasn't been approved. I can barely walk. I need medications. And it can be frustrating as their treatment provider.